Good afternoon, everybody. I myself, Jeeva, working as nurse in Ward 4A. Today, we are dealing with topic cardiomyopathy, dilated cardiomyopathy. Before going to this, we should know what is cardiomyopathy. In 1980s, the cases was not relevant and the disease was not clinically relevant. So the etiologist was not identified. So they WHO defined cardiomyopathy just as a disease of the heart muscle. And in 1995, the cases become increased and the etiological factors identified, and this become most clinically relevant. And then they define cardiomyopathy as the disease of the heart muscle associated with cardiac dysfunction. Based on the anatomy and physiology, WHO classified cardiomyopathy into different categories, that is into different classes, mainly into 5. First one is dilated cardiomyopathy. There will be elongation and dilation of one or both ventricles, and then mainly the systolic function is affected. And the second one is hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, there will be thickening of the myocardium, and mainly the diastolic function is affected. Interventricular septum also involved in this. And then third one, there will be systolic dysfunction. And the third one is restrictive cardiomyopathy. In restrictive cardiomyopathy, there will be restricted filling and decreased diastolic volume of the ventricle with near normal or near normal systolic function and normal wall thickness. That is the main difference between these three. Is in dilated cardiomyopathy, the diastolic function is impaired, and then in systolic function is impaired. In hypertrophic cardiomyopathy, there will be increased thickening of the myocardium and the diastolic function is impaired. In restrictive cardiomyopathy, the diastolic function is impaired and there will be no thickening of the myocardium, but there is restricted filling. And then the next one is arrhythmogenic right ventricular dysplasia. In arrhythmogenic right ventricular dysplasia, there will be progressive fibrofatty replacement of the right ventricular myocardium. Later, it may progress into left ventricle also. And the last one is unclassified. That is, if this dilated cardiomyopathy, it cannot be classified under these four, then it is comes under in the unclassified. That is fibroelastosis. Next, we are dealing with dilated cardiomyopathy. Dilated cardiomyopathy is defined as the disease of the heart muscle characterized by elongation and enlargement and dilation of one or both ventricles, along with impaired cardiac contractility, defined as left ventricular ejection fraction less than 40%. There will be, that is the disease of the heart muscle with elongation and dilation of the ventricles. What is impaired? There is contractility is impaired. That is left ventricular ejection fraction will be less than 40%. Then the incidence of this dilated cardiomyopathy, mostly the prevalence in general population is 36 per 1 lakh population, and the incidence is more, that is 2.5-fold increase in blacks than the whites, and 3-fold increase in men than women. And the most cases diagnosed between the age group of 20 to 60 years. Then the etiological factors. The etiological factors mainly include idiopathic. That is the most common etiological factor for dilated cardiomyopathy. That is the exact cause is not identified. Then next one is ischemic heart disease. In ischemic heart disease, there will be narrowing or obstruction of the coronary arteries that can lead to dilation and elongation. Then next one is valvular. Valvular means there will be too narrow or too leaky valves that can cause dilation. Then third one is hypertensive. hypertensive मतलब if the hypertension or diabetes is not under control, that can leads to this condition. Then familial that is inherited. There may be autosomal or recessive inheritance of this disease condition. That is genetic mutations may occur. In autoimmune disease that is polydysplasia, polymyositis. This like these conditions can also cause DCM. Then infective, inflammatory. It includes HIV, HIV disease infections, Lyme disease, Coxsackie B virus. Uh, all this can lead to inflammatory dilated cardiomyopathy. Then peripartum. Peripartum means in the last month of the pregnancy or within 5 months after the delivery, the lady is at high risk for this dilated cardiomyopathy because there will be physiological changes that can lead to can lead to this dilated cardiomyopathy. Then toxic means that is toxic substances such as metals, like exposure to the metals like arsenic, lead, lithium, or to the that is abusive use of the alcohol, cocaine, or due to some medications such as doxorubicin, daunorubicin, methamphetamines. All these can lead to cardiomyopathy. Then nutritional and neuromuscular. Nutritional and neuromuscular means if there is thyroid problems, that is, or if there is iron or ferritin deficiencies. Or neuromuscular means if there is polymyodystrophy, all this can lead to dilated cardiomyopathy. Based on this, they are given different type names for this dilated cardiomyopathy based on these etiological factors. That first one is diabetic cardiomyopathy. If there is no evidence of such cardiac problems, that is, if there is no conditions which define to the cardiac muscles, but or the coronary arteries or valves, but there is cardiomyopathy in the persons with diabetes, then it comes under diabetic cardiomyopathy. Then next one is familial cardiomyopathy. Familial cardiomyopathy means that we have already discussed that familial inheritance, that is autosomal or recessive inheritance may occur. If it is like that, that is comes under familial cardiomyopathy. Then idiopathic cardiomyopathy. If there is any identifiable cause, that is idiopathic cardiomyopathy, exact cause. Then ischemic cardiomyopathy. This cardiomyopathy occurs due to this coronary artery diseases, and it becomes under this. And then peripartum cardiomyopathy. Peripartum, that is if in the last month of the pregnancy or within 5 months after the delivery, if she develops cardiomyopathy, that comes under this peripartum cardiomyopathy. Then primary cardiomyopathy. If the structural or anatomical structural or physiological changes of this cardiac cells is due to these conditions of the cardiac myocytes itself, then it is called primary. That is, the disease starts from within these cardiomyocytes, not other causes. Then pathophysiology. If due to these all etiological factors, the heart cannot pump enough blood, that is decreased, there will be decreased cardiac output, systolic or diastolic dysfunction of the heart, and there will be decreased cardiac output. This causes mainly this leads to mainly two physiological activations. That is, first one is renin angiotensin mechanism, or second one is epinephrine and norepinephrine release. When the norepinephrine is released, that will increase the heart rate, increase the contractility, and increase the oxygen demand of the heart. That in turn leads to increased dilation and hypertrophy. Then second one is renin angiotensin aldosterone mechanism. That is, when there is decreased cardiac output, the kidney will release renin, and then that can activate angiotensinogen to angiotensin 1. Then angiotensin 1 is converted into angiotensin 2 by angiotensin converting enzymes, and this angiotensin 2 itself causes peripheral vasoconstriction, or it can lead to activation of that can cause the release of aldosterone from the adrenal medulla. Adrenal cortex that leads to the release of sodium and water retention, and that in turn leads to workload of the heart and dilation and hypertrophy. Next, we are dealing with sign and symptoms. The main sign and symptoms of dilated cardiomyopathy can be discussed under 3 headings, that is due to lower oxygen, or due to heart failure, or due to changes in sign and symptoms due to changes in the heart. Due to low oxygen, the person may feel altered level of consciousness and decreased energy and syncope or dyspnea and angina, shortness of breath. Mainly our patients are coming with this shortness of breath. Then heart failure. Heart failure signs and symptoms mainly depends on whether it is right ventricular right heart failure or left heart failure. If it is left heart failure, that can lead to the congestion in the pulmonary system and increased pulmonary resistance, and that can lead to pleural effusion, crackles, and shortness of breath, etc. And if it is to right heart failure, there may be generalized symptoms is increased jugular venous pressure and hepatosplenomegaly, peripheral edema, all these ascites, and then changes in the heart. There will be mitral valve regurgitation, S3 gallop, or peripherally displaced PMI, narrow pulse pressure. Then physical examination findings. Physical examination findings include due to decreased cardiac output, we can feel cool clammy extremities, tachycardia. There will be decreased narrow pulse pressure, increased pulsus alternus, and that is in the end stage. And then next one is pulmonary venous congestion. Due to pulmonary venous congestion, there will be crackles, pulmonary edema, and pleural effusions, and shortness of breath. All these can be. Then cardiac. What is cardiac symptoms? Mainly include the person may feel the peripherally displaced PMI, S3 gallop, mitral regurgitation, and last is systemic congestion. Systemic congestion, ascites, peripheral edema, increased jugular venous distension, and hepatosplenomegaly, ascites. Then what are the diagnostic studies? Diagnostic studies include chest X-ray, ECG, blood test, endocardiography, cardiac catheterization, myocardial biopsy, cardiac MRI. First one is chest X-ray. In dilated cardiomyopathy, there will be laterally displaced PMI. That is, the enlarged heart can be seen, but the change in size and shape of the heart can be seen here. Or in X-rays, there may we can see interstitial infiltrations or pleural edema, pleural effusions can be seen. Next one is ECG. There will be ECG changes, but it is not will not be specific to this dilated cardiomyopathy. Then blood test. We will test ANA. That is we have already discussed that autoimmune or inflammatory these conditions can lead to dilated cardiomyopathy. That is ANA, rheumatic factor, thyroid function test, or iron for retin. All these can have to perform. Then echocardiography, that is the gold standard test to detect the dilated cardiomyopathy. Echocardiography, what are the changes that we can see is there will be elongation and dilation of the heart chambers, hypokinetic heart chambers, that is decreased movements, that is decreased contractility, and the left ventricular ejection fraction will be less than 40%, and the end diastolic diameter of the left ventricle will be more than 2.7 centimeter per meter square, and the shape will be altered to globular, and sphericity index will be changed, that is short axis long axis ratio will be changed. Then cardiac catheterization. Cardiac catheterization is mainly done to exclude that the DCM is mainly due to coronary artery occlusions, and then that can also influence the therapeutic management and the prognosis of the patient with DCM. Then endomyocardial biopsy. Endomyocardial biopsy is done to that is histological, electron microscopy, immunohistology. All these can done to detect that can helps to predict the management or to detect the prognosis of the patient. That is, if it is idiopathic, DCM has more prognosis than other DCM. In cardiac MRI, in this also we can see the enlarged ventricle. Then gross findings. Gross findings, we can see the change in size and shape of the heart. That is, the shape of the heart become globular and the weight will be increased. Dilated chambers. Then microscopic findings. In microscopic findings, the atrophy of the myocytes can be seen as dark red, or the increased interstitial fibrosis is pink in color, and the collagen fibers will be increased, and the myocyte will be elongated and with a thin cytoplasm. Then what are the complications of DCM? The main complications of DCM, as we all know, that is heart failure. That is, the heart cannot pump enough blood due to systolic or diastolic change in size and shape of the heart. The heart cannot pump enough blood to meet the demands of the body. That is, the heart failure. And then arrhythmia due to these changes, that is due to the anatomical and physiological changes of the heart. Ectopic beats may arise, irregular rhythms may be seen. Then sudden cardiac arrest. Most of the patients may have sudden cardiac arrest due to these arrhythmias. And blood clots. Blood clots is mainly due to the pooling of blood in the lower extremities that can distort to other organs, that is renal, pulmonary or brain, that all to other complications. Then the management of DCM. Management is mainly aimed to maintain the normal cardiac output or decreased fluid overload. That is, treating fluid overload and maintain the normal cardiac output, and to identify the etiological factors and treat the underlying cause. The last one is to prevent the or progression of the complication and the complications. The management of dilated cardiomyopathy can be discussed under mainly lifestyle changes, medical management, surgically implanted devices, and heart transplantation, and new treatment strategies. About these lifestyle changes, we have to control the diet. That is, additional salt should be avoided, and additional sugars should be avoided. Is fiber in the diet, and saturated fat should be reduced. The next one is about the about the use of alcohol, cocaine, or stress management, that is exercise and weight management. We have to control the normal body weight, and we have to perform daily exercise, and strenuous exercise should be avoided. And then the last one is stress management. Adequate sleep and rest is important. Then medical management, the first line therapy is mainly directed to decrease the fluid overload and to maintain the cardiac output. We can use the medications that to control the BP and to improve the peripheral circulation, that is peripheral dilation, and to decrease the fluid overload. We mainly use the BP medications, and anticoagulants may be used. It includes ACE inhibitors. ACE inhibitors are mainly used when there is symptomatic heart failure or asymptomatic left ventricular failure. There is symptoms of heart failure or there is left ventricular failure without any symptoms, then we are using ACE inhibitors. If the patient we have intolerance to ACE inhibitors, we use angiotensin receptor blockers or hydralazine nitrates. And then we use diuretics to decrease the fluid overload, or we can use warfarin is mainly digoxin if there is persistent heart failure in spite of this ACE inhibitors and other medications. Then warfarin is used to prevent the blood clots, arrhythmogenic blood clots or paroxysmal AR. Beta blockers is also used in symptomatic heart failure. Then surgically implanted devices include left ventricular assistive device, implantable cardiac defibrillator, biventricular pacemakers. Then biventricular pacemakers are used to these devices cannot manage DCM, but can control the symptoms and the complications of DCM and can improve the quality of life. That is, if biventricular pacemaker that is used in case of arrhythmias, these pacemakers are implanted then to get the normal rhythm. Then implantable cardiac defibrillator. This also implantable cardiac defibrillator. This diagnose the rhythm itself and then provide electric shocks to when there is abnormal rhythm. Then left ventricular assistive device. In left ventricular assistive device, it is a mechanical pump that helps to that helps the heart to pump better. Thus, to improve, that can use for short term or long term. If it is for between, that can also use as bridge between the heart failure and the before receiving the heart transplantation. That is, if then heart transplantation. Because this less invasive managements, the patient have persistent heart failure, and to improve the ultimate management is this heart transplantation. That is, the heart is transplanted that can improve the prognosis and increase the quality of life. The new modern treatment strategies. New treatment strategies include gene therapy, stem cell transplantation, cardiac reprogramming. And gene therapy, mainly introduction of the foreign gene into the target cells. Mainly this has mainly two aims. First one is to correct the defect in the gene itself, or it can use to correct the pathophysiological changes caused by this defective gene. So second one is stem cell transplantation. Stem cell transplantation means stem cell is has a unique characteristics that it can differentiate into cardiomyocytes, smooth cells, or any other cells. That is, it can be embryogenic, or embryogenic cells can be used, or the adult stem cells. Adult stem cells means skeletal smooth muscles, skeletal muscles, bone marrow cells. All this can leads to this can differentiate into cardiomyocytes. Then last one is cardiac reprogramming. Cardiac reprogramming is transferring the cardiofibroblasts into cardiomyocytes. These are under research studies, and these are new modern strategies. Then nursing management mainly include the main diagnosis is ineffective impaired gas exchange related to pulmonary alveolar edema secondary to increased left ventricular pressure. Impaired gas exchange, mainly we have to in nursing interventions are we have to assess the respiratory pattern of patient. That is respiratory. We can assess the respiratory pattern, rate, rhythm, and we can auscultate the lung fields, and we can change the position of the patient every 2 hourly, and can provide adequate rest between the activities, and we can administer oxygen, or we can administer the medications, and we can provide bed rest to the patient. Next one is ineffective ineffective tissue perfusion related to decreased cardiac output secondary to cardiac muscle damage. What our main interventions are, we have to ineffective tissue perfusion, that is we have to assess the tissue perfusion, that is we can assess pulse, BP, or capillary refilling, and we have to assess the in order main first change will be in the level of consciousness. If it is impaired circulation to the brain, so we have to assess level of consciousness of the patient, and if there is renal impairment, that is if there is decreased perfusion to the renal, there will be decreased urine output, so we have to maintain eye input output chart, and if there is decreased circulation to the peripheral perfusion, we can assess the peripheral pulse and peripheral capillaries, and we have to provide complete bed rest. Then next one is excess fluid volume related to decreased glomerular filtration rate and decreased cardiac output secondary to cardiac muscle damage. Then we have to weight the patient, daily weight monitoring should be done to the patient, and we have to maintain strict input output chart, and we have to administer the medications, and we have to decrease the we have to administer low sodium diets, and fluid should be fluid volume intake of the fluid should be minimized, and if there is we have foam address should be provided, and plus skincare should be provided as the increased chance for bed sore. Next one is activity imbalance related to imbalance between the oxygen supply and demand of the secondary to cardiomyopathy. Activity intolerance, we have to provide rest between the activities, provide assistance to the activities, and check the baseline vitals, and then check the changes in the cardiac function during the activities. Then prognosis, we have already told that the increased prognosis more in women than men, and 20% of the patients dies within the first year of the diagnosis, and 40 to 50% dies in deaths are sudden. And the prognosis depends, we have already discussed that the prognosis mainly depends on the etiology. In this graph we can see that the main increased surveillance rate is, that is prognosis more for the peripartum cardiomyopathy and idiopathic cardiomyopathy, and other causes, that is ischemic heart disease or doxorubicin toxicity, the prognosis, that is surveillance rate is less. Then the health education that we have to give to the patients when discharging. First one is regarding the diet. Low sodium diet should be included, and low fat, low carbohydrate, and fluid restrictions, and they have to avoid the strenuous activities, that if the patient is surgically implanted devices, then they should be conscious about the physical strenuous activities. Sports activities should be avoided, contact sports. Then about they should avoid alcohol and cocaine, and they have to maintain normal body weight, and they have to provide rest and sleep to the person, and thank you. ഇതിലിനി എങ്ങനെയാണ് കേട്ടോ?